Hi, everyone. Today I want to introduce Alexandra Reynolds. She's assistant professor of neurosurgery and neurology at the Icahn School of Medicine at Mount Sinai and a board-certified neurointensivist. She serves as director of tele-neurocritical care for our department and the health system. And we want to share some of her stories today about taking care of COVID patients. Since joining us, she's become an extremely valuable and active member of the department and one of the linchpins of our neurocritical care division. What is your usual role within Mount Sinai? What have you been assigned to do during the COVID-19 crisis?
I'm a neurocritical care doctor, which means I take care of neurological and neurosurgical patients in the intensive care unit, either because they've had some catastrophic event happen or because they've had a planned surgery. And so I usually am taking care of neurological patients in an intensive care unit. Since the COVID crisis has started, I spent a lot of time on the rapid response team, which I usually do, but just to a lesser degree than recently. And so that kind of means I respond to emergencies within the rest of the hospital, and kind of triage which patients need to go to the ICU. And since COVID, there's been a lot of pretty sick patients on the floors. And because it's been so difficult to assess which patients are going to decompensate, I've been doing a lot of emergency airways on the floor. And then the last thing that I'm going to be doing, but I've had to be away for a while, so I haven't started yet, is working in the COVID ICU, which I actually haven't been able to do yet because I got sick before I could start.
Can you describe what your new day-to-day life is like?
So, you show up in the morning and anywhere in the hospital that has a crisis is just going to page you and ask you to rapidly respond to that patient's room. And so you're taking care of a lot of patients who you don't know and you're meeting for the first time when they're in extremis. And so your job is to try to rapidly assess the patient and see what their needs are, determine whether they need a higher level of care or not. Oftentimes you're seeing the patient for the first time and discussing really distressing stuff. A lot of times my job would be to go in and explain, you're getting worse, and we're giving you the maximal amount of oxygen that we can give you, not invasively. And so the next step would be to put you on a ventilator. And so you're having these pretty intense conversations with patients that you've never met before. And you're telling them that they're getting worse and that, they may not be able to continue to speak with their loved ones, and that they're kind of entering a new part of their care that's kind of scary and unknown. So that's a little difficult to do. And you obviously do it with the team, but your job is to really transition the patients into a higher level of care, which can be difficult. These patients have been seeing a lot about COVID on the news, and they've been hearing things that are true and things that are not true. And so when you're, now seeing the patient in extremis, you're kind of also fighting with a lot of what they've heard on the media and a lot of their preconceived notions of what this might be. And they're really, they and we are kind of unprepared for what comes next. And so it's been interesting to talk to these patients because none of us really know everything about COVID yet. And so you're trying to educate them, but you don't have enough information either, really. And so there's a lot of unknowns that you're kind of trying to negotiate with them as you're trying to counsel them on what to do next.
Tell me what it's like in your unit now.
It's definitely been difficult, I think, for the entire hospital system to try to come to terms with this new disease that's taken over our hospital that we're not really, we don't have a lot of experience with. But what it's really done, I think, is brought together everybody. So we're all kind of in it together and bonded over our kind of all the stressors that come with dealing with a disease process that we're not familiar with. So certainly on the floors, the floors have had to rapidly increase the number of sick patients that they can take care of, because there just aren't enough ICU beds. So there are patients who are requiring a lot of oxygen who are on the floors, and the nurses and the PCAs and the PAs, NPs, physicians, everyone who takes care of these patients have had to be very flexible about trying to take care of patients in a way that used to feel maybe unsafe, but now we kind of just have to all get better and take care of sicker patients under, you know, worse circumstances. So we've really all kind of bonded together and become more of a team. I've certainly worked with hospitalists really closely that I'd never really worked with before, who, you know, were on the phone with each other all night trying to triage who needs to move and when. So getting to meet a lot of new people that I've never really worked with closely before. And certainly a lot of the same nurses we were seeing over and over again over several shifts, as we're all trying to get used to what this new disease is like. It's also been different on the floors because there are no families. And that's something that I think is really odd, particularly for someone who works in an intensive care unit where we're used to seeing families almost all the time. It's a very different experience to take care of people without being able to communicate with their families effectively. Certainly, you know, there was a patient I was kind of counseling about how he was going to need to be put on a ventilator soon, and we called up his wife on speaker, and we, you know, the three of us had a conversation, and, you know, the patient is on oxygen and short of breath, and I have my mask on and my PPE, and it's very difficult to hear me, I'm sure. And, you know, all I could think about was how hard it must be for this patient and his wife to not be physically together. And then even just the small things about communication, like being able to hear over the suction and the oxygen that's blasting in the room, being able to hear through my mask, and not being able to make eye contact necessarily. It's a very different environment than I think I'm used to. And, you know, as an intensive care doctor, we do a lot of conversations with families. And I think something that we value is being at the bedside, being able to speak one-on-one with a person's family member. And it's been very difficult to try to have those conversations. I mean, it's great that we have telecommunications and FaceTime and all these other things, but it's still not quite the same. You know, we all try to minimize the amount of time we spend in the room for safety reasons. And when we go in there, we're covered in PPE. We look like space monsters. And I can't imagine how isolating it is for a patient to not see their medical providers all day in and out, to not be able to even see our faces or our expressions. I think that must make everything a lot more difficult for them.
How has your role in the neurosurgery department prepared you for this new role?
I think in neuro, I have a little bit of a leg up on others because there is so much uncertainty in neurology and neurosurgery compared to other fields of medicine. So in that sense, I feel a little prepared to kind of at least be able to discuss the breadth of what might happen, even if we don't know exactly what will, like this is best case and worst case scenario. But certainly, yeah, it's hard when you don't feel like an expert because no one is at this point. And that's also been hard to discuss with patients and their families because we're all kind of flying blind a little bit. Neurointensivists usually try to consider themselves intensivists first. So we're ICU doctors first, and then we're neurologists second. The reason being that it's not just about preserving the brain, because if the rest of the body falls apart, then, you know, your efforts to save the brain are kind of moot. And so we are in a unique position of, you know, being in the Department of Neurosurgery and understanding neuroscience, but also being able to treat critically ill patients who are in organ failure. So, some of the skill set that we have as intensivists are things like being able to access an airway, being able to manage someone on a ventilator, being able to decide when a patient needs dialysis, and being able to manage a patient who is in shock for various reasons. And so we've been seeing that these patients with COVID certainly go into respiratory failure, but they do also have multi-organ failure. And so while we're not experts by any means in COVID, we are able to manage patients who have multiple organ disease and patients who need ventilators. So in that sense, I feel, more prepared than someone who is an outpatient doctor. A lot of what we do in the intensive care unit is also talk to patients and families and try to assess goals of care and what's really valuable to a patient. And so obviously in the critical care nature of this disease process, we've had to rapidly counsel people about what sorts of invasive therapies they would or would not want. So those are certainly skill sets that I think we as intensivists and neurointensivists have kind of been able to use during this disease process.
What sort of new skills have you had to acquire to do your new responsibilities?
One of the big things that we were doing on the floors for emergent intubations was we were having 2 attendings in the room doing all intubations. So 1 anesthesia attending and 1 critical care attending. So I've actually learned a lot about how anesthesia intubates, which is a very different skill set than my skill set. Anesthesiologists are very, they're usually intubating patients who are there for an elective procedure and are optimized as much as possible. And they have a very specific way of thinking about all the steps of an intubation because they do the same thing 10 times a day. Critical care doctors, I think, have to be a little bit more flexible because we're usually emergently intubating someone and it's never ideal. And so we kind of allow ourselves to do things under less than ideal circumstances. And so it's been really nice to kind of watch how someone who has a very regimented way of doing something does something even in an emergent situation. So I've certainly learned a lot about airway, I would say, from the anesthesiologists. I've learned a lot about management of severe ARDS from our pulmonary colleagues. I've learned how to prone now. So that's when you flip a patient onto their stomach to improve their oxygenation, which is something that probably the neurosurgeons really know how to do because they're always flipping patients over for spine surgery. And obviously it's a little different to flip someone who's super unstable and not oxygenating well. But our pulmonary colleagues do it all the time and they were kind enough to show us how to do it. So that's a skill set that I did not have before that I will hopefully not to have to use very much after this is all over. But I really think that in some ways, because we all have different ways of dealing with these super sick patients, we've all had to kind of learn from each other, which has been really nice. There have been a lot of reports on patients with COVID having increased incidence of stroke. And so I think in some ways it's been nice to have that neurological background because a lot of my colleagues have been telling me that they've been seeing patients with focal neurological issues and identifying patients with strokes. So I think a lot of non-neurological people are learning a little bit of neurology too, despite this being a primary infectious disease. The protocols are changing every day. So we have daily updates from the Institute of Critical Care Medicine to try to keep up with the latest protocols, the latest data, and certainly the availability of space and ventilators and medications is changing on a day-to-day basis. So there's a constant need to be flexible and creative because you never really know what's happening the next day.
How are you feeling?
I started having symptoms about a week after my first rapid response shift. I had been doing emergency airways, and some were in less than ideal conditions just because they were so emergent. And so about a week after one of my shifts, I had a sore throat at the end of my night shift, and I felt really tired. But I'd also done, 6 shifts in 8 days. So kind of brushed it off as, I'm exhausted from seeing all these patients and running around all day and all night. The next day I developed a cough, and at that point I was kind of on the lookout for symptoms, because we all just know that it's a risk of contracting COVID. So I spoke to my supervisor, and, we just agreed that I would check up on my symptoms and keep a close eye. And then later that day I spiked a fever. So at that point I was like, this is presumed COVID at this point. And at that point, I really started to get worried about my husband and my baby, because we had chosen not to live apart during this. And I had just tried to be really careful about changing my clothes before leaving work, and leaving my shoes at work, and, all sorts of crazy ways of not giving COVID to my kid and my husband. So I isolated myself within our small apartment as best I could. And then the next couple of days were really bad fevers. It just felt like the flu times 100. Fevers, chills, night sweats. And at that point, my baby also started having fevers. So at that point, I figured that I had given it to him. And then, interestingly, I lost my sense of smell and my sense of taste, which has been the most bizarre part of this, I think, because a lot of the other symptoms are very similar to having the flu. But I don't think I've tasted anything in like 5 or 6 days now. Makes changing diapers a lot easier, because I can't smell anything. But yeah, I'm starting to feel better. I definitely feel exhausted, and that's coming from an intensive care doctor who recently had a newborn. So the fact that I'm really tired, I think, is a significant symptom. But I haven't had fevers anymore, so I am cleared to come back to work, as long as I don't cough on people. So I have to be wearing a mask, obviously, at all times. It's incredibly frustrating to not be able to go into work. My colleagues had to cover my shifts, which I felt super guilty about. And I also just have a little bit of FOMO, I think. Like, I actually really like my job. So the fact that I don't get to go into work and I don't get to geek out about, what everyone's doing with the ventilators and how to best optimize all this stuff. I've been kind of living vicariously through Twitter, medical Twitter, just to keep up with what's going on. And I just miss my colleagues. I haven't seen my colleagues, the nurses that I work with. They've all been texting and checking up on me, but I miss working with them. And now that I feel like I have the disease, I'm hoping that I have a lot more immunity. And so once I go back, I'm really hoping to be able to relieve a lot of the people who haven't gotten it, because at this point, it probably is safer for me to go do airways than for, the average person who hasn't gotten it. So I'm kind of itching to go back and kind of start working again. I've noticed that the less I work, the more worried and anxious I can get. And so it's not good to be at home and be idle. And even though it's been great to hang out with my child more and see him a lot more than I have been, I think the more I am at home and just sitting and thinking about what's going on, the more I kind of devolve into thinking about what could have happened to me, or like, I'm so lucky that I had a fairly mild case of it. But it just makes me worried about everyone else out there. And I kind of want to go in there and relieve some people so that we can just kind of reduce their exposure. Once I realized that I had given it to my husband and my son, and I started to kind of go down that rabbit hole of what's going to happen if one of them gets super sick and ends up in the hospital, and how could I have brought it home to them? I think that was very difficult. Just the feelings of guilt about bringing it home. And certainly the more time you have and the more horrible stuff you've seen, the more likely you are to kind of catastrophize. So as soon as I was quarantined at home, I worked on my will, filled out a healthcare proxy form, worked on my living will, and really started in a way that I hadn't before. I started thinking about what would happen if my healthcare proxy and my backup healthcare proxy were both sick. Like, who would be my third backup? Because we had seen so many people with family members in the hospital who really didn't have decision makers at that point. And so once I was at home, I was kind of thinking, well, all right, well, what if my husband's sick and my brother gets sick and my parents get sick? Like, who's going to make decisions then? So it's been, in some ways, I think it's been good because it's important to think about those things. But it's kind of forced me to think about it a little sooner than I maybe wanted to.
Do you think your life will change in long-term ways because of this crisis? How do you think healthcare is going to change?
Well, I hope it changes healthcare, because I think in a lot of ways, this has become so difficult to manage because of the way that a lot of systems of care had been functioning. And that's, a lot of it is on a political level and a funding level. But I think something like this really, to me, indicates the importance of us making sure that everyone has access to healthcare, right? Because I can get sick from someone sitting next to me on the subway who doesn't have access to healthcare or doesn't have the sick days to stay home from work. And I think what we've all seen as a society and as a community is that none of us are an island. We all are interconnected, and everyone's actions really affect everyone else in terms of their health, their safety. And so I think on a societal level, I'm hopeful that this has sort of changed the way that we view each other and the importance of taking care of each other, because it's also about taking care of yourself at that point. In the hospital, I'd say, I think we've had to learn how to be flexible and how to take care of really sick people together, even if we don't necessarily all know what we're doing. And I'm hopeful that that kind of like camaraderie continues even once we're all back to, siloing ourselves in whatever disease or whatever organ we are experts in. And I'm hopeful that all of these relationships that we've been able to make and all these new colleagues that we've met kind of just really help improve the environment in which we work in, and continue to keep it as like a friendly, collegial place where we're all kind of in it together. And then in terms of, I think the way that I approach patients, I always thought I did a good job with patients because I had been in an ICU as a patient when I was in medical school. And so I thought that I was pretty thoughtful about making sure that patients were comfortable and thinking about how to speak to patients. But I think that this experience has really brought out a couple of things that I hadn't really thought about. Before intubating someone and putting them on a ventilator, giving a patient some private time to just make some phone calls and talk to their family because you don't know what's going to happen, has been something that I've adopted. Even if it feels like it's an emergency, you do have 5 minutes to let a patient make a phone call while you're setting up. And so I think little things like that, I'm probably going to take with me and kind of change the way that I interact with patients and their families.
What would you like other people to know about what you are experiencing and what we are experiencing taking care of this crisis?
I never would have expected that we would have issues with resources in New York City. I am a New York City girl, born and raised. I'm super arrogant about how awesome the city is compared to everywhere else in the country and world. And it never crossed my mind that I would have to think about whether we had enough supplies, whether we had enough staffing. I think I've always worked in this bubble of thinking that we had everything that we needed and even more. And so to function in an institution which, because of the overwhelming number of patients, we've had to think thoughtfully about how we're going to reuse supplies, or be careful about what sorts of interventions we're doing. I think this was not ever something that I could have imagined. And certainly when reports were coming out of Italy, I think a lot of us were like, well, that's not going to happen here. There's a little bit of like American and even New York exceptionalism that I think runs through even the best of us. I just think I want people to recognize how hard it is to work when you feel like you don't have enough medications, enough supplies, when you're not sure if you can provide the best care to a person because you're taking care of too many people or you don't have enough resources. I think that's been a very difficult part for all of us because we all pride ourselves on giving the best care to our patients. And when you're stretched thin, you have to come up with different ways of making sure that you're still providing that excellent care to every single patient. And I think the other thing that we all had experienced on a daily basis, but I don't think the public really knew, is the sacrifices we make for our families. Missing my kids' bedtime every day happened even before COVID. It's just that now with COVID, people are recognizing all the other types of sacrifices, putting your health on the line. But I think we've always been making those sacrifices. It's just that no one really noticed. And so in some ways, I think this has amplified the experience of a healthcare worker in the hospital.